Okay, so we have now arrhythmias, and we're going to talk about arrhythmia 1, and then we have arrhythmia 2. So arrhythmia 1 is going to focus on atrial problems, and arrhythmia 2 will focus on ventricular problems. So just as Monday we were talking about the P wave, QRS, and the T wave, let's remind ourselves, what does the P wave mean? Atrial depolarization, which is the same thing as atrial contraction, stimulation, yes. PR interval, mostly so from here to here, repolarization of the atrium, yes. QRS complex, this one right here, which one, what is this one? Tell us about. Ventricular what? Depolarization, ventricular contraction, right? And then we have the ST segment. So what does it sometimes tell us? Whether someone just had a NSTEMI, like a MI, a heart attack, right? So if it's elevated, it usually means they had a heart attack. If it's depressed, it usually means that it's angina, but you can have a non-elevated MI as well, right? But it does tell us that. The T wave, repolarization of the ventricles, right? So that's the time the ventricles take to fill back up with blood. Awesome. And the QT interval is connected to ventricles. So we say that that is our most specific, or that's the one we monitor the most. Even though P or the atrium matters, ventricle issues, we worry about them more because they cause more damage. Okay, so let's see. Okay, let's move on. So we're going to look at refractory period. So when we think about refractory period, what that means, let's say we have absolute and we have relative. So absolute refractory period is a time during the electrical conduction that the heart is unable to respond to a new stimuli. So during this stage here, the heart cannot get another stimulus to contract, right? It should not. Right? So that's why when we have the defibrillator, it's analyzing the rhythm, it's checking to see where the rhythm is so that it does not send a signal here. Because if you do, you can cause trauma. You can cause the person to, you can cause the heart to stop, right? So we definitely do not want to send a signal here. And it is very hard for the heart to receive a signal here. It doesn't usually. Now, if it's going to send a signal, it's going to send it starting here. That's a relative refractory. So it doesn't really like it, but it will accept it. And so if you have a person who has a ectopic area where they're receiving signals, that's where the signal will start happening for them to have another initiation of another signal that is relatively not really good for it, but it does happen. So relative refractory, short period after the firing of the nerve fibers where partial repolarization has occurred and the heart can respond to a new strong stimuli. So let's talk about what the boxes mean, okay? So what do the boxes mean? So we kind of started off Monday talking about the boxes, right? So we have 0.2 seconds, right? We have 0.5 millimeters, and one box is 0.04 seconds, right? So the full length of the box, when we say a bigger box, is a 0.2 seconds. One of those small boxes within the bigger box is 0.04 seconds, and the length is 5 millimeters that way. Okay, so this illustrates the configuration of the ECG graph paper and where to measure the components of the ECG wave. Okay, so each small box, 1 millimeter in length, represents 0.04. And each larger square, 0.20 seconds. Okay, so now let's determine the rate. Again, as I mentioned in class on Monday, you should be or could, if you're not able to, just look at a strip and recognize it. But if you're going to be working in telemetry, not all of them are that quick to recognize. And you're going to have to start learning how to use, how to measure it in order to identify it. But in my class, the ones that I'm giving you, you could just look at it and recognize it. But I'll still show you how to determine the rates, okay? So how do we determine the rate? So to calculate the heart rate, we first need to know, is it regular or is it irregular, right? So to figure out if it's regular or not, we first look at the R to R interval. So first we want to identify, this is not very clear, but we want to find a peak that is located on a line, right? And then we want to count from that distance, or look from this distance here, okay? So once we find one that's on a line, it will be easier to do our measurements or our calculations, right? So first look at the R to R interval. We are looking at the distance between the different peaks. If the distances between the R to R is roughly the same distance, it is regular. Makes sense, right? So if we look out from here to here, from here to here, from here to here, and we're like, the distances look about the same, so that means it's regular. So what I would say, if like you're not able to tell, right, I would get a sheet of paper, right, and literally put the paper next to it and then mark, right? Okay, it ends here, so I mark. And then I use the edge and I see, oh, same place, it ends, right? So that way it tells me, do you guys get that? Right? Just to see if it's measured equally. Because sometimes your eyes might not be able to give it to you, but most times it's really obvious, okay? So now that you have found that this is regular, okay, so, but if some are longer distances and some are shorter distances apart or inconsistent with each other, they are considered irregular. So we use the 1500 method or the 300 method when we have regular rhythms. So for irregular rhythms, right? So, well, let's finish with the regular. So what is the rule of the 1500? So the 1500 method, first, again, you decide which peak is the best to choose. You find a peak that is on one of the solid lines. So let's say we find that one and we bring it down. So this is it right here. Then count the number of small boxes between two successive R waves. So you find the one that's on the line and then you get the one next to it. We usually go forward and not backwards. So we get to the next one. And then we count how many boxes. We say this is 1, this is 2, this is 3, and this is 4 with a little bit of extra. Okay? So you count the number of small boxes between the two succinct R waves or two peaks adjacent, right, next to each other. From solid pink line to solid pink line is 5 small boxes, right? So we have 5, 10, 15, 20, right? So we had 1, 2, 3, 4. So now 5, 10, 15, 20. Okay. So next you will take the 1,500 or 1,500 and divide it by the number of small boxes. So it will be 1,500 divided by 20. And then we put 1, right? Because that looks like it's like 1. Okay. Since this is like 5, so it's like 1, 2. So that's 1. So that's 21. And this works well for regular and fast heart rates. So that is how you do the rule of 1500. Okay? So first, again, let's say it again. We first look at solid line. Which peak is on a solid line of all of these peaks? And we're like, this one is on a solid line. So we bring it down. Okay, so we're choosing this one to the next one over, right? Then we count how many boxes are between 1, 2, 3, 4. Okay, or we say 5, 10, 15, 20, right? And so it's 20, and there's a little extra space, so we put 21. So then we have the 1,500 over the 21, and that will give us the heart rate. Got it? Okay. So now let's see. For the rule of 300, they say it's a little less accurate. So first you determine the rhythm. Is it regular or irregular? Once you find that it is regular, you note that, let's see, find a peak, same way, find the peak. Let's see, do I have it down here? Do I have it in the next one? No, that's a different one. Okay, I need to have another slide for this one. Okay, so then for the rule of 300, right? Once you note that it's regular, you find a peak and you go to the adjacent one next to it. Then you want to designate specific numbers. This one you have to memorize, right? So you would say the first box over is supposed to be 150. Then wait, no, the first box, sorry, hold on, let me make sure this. The first box is 300, so this is 300. Then the second box is gonna be 150. Then the third box is going to be 100. And the fourth box is gonna be 75, right? And then the fifth box would have been, what is it? 60. So you have to memorize this, right? And so then once you put that down, then you have to say, let's see.
So 5 of the small box, or 5 of the large boxes is 1 second.
So what do you say? 5 of these, 1, 2, 3.
So those are the small ones. So 5 of the large ones would be like 1 second.
So 5 of these?
Yes.
Like 1, 2, 3, 4.
And
5 would be 1 second. Yes, because they're
And it would be
points.
60 beats per minute.
Yes.
So 1 beat per second.
Yes. So what we're doing is we're counting the boxes, right? We're saying for the 1500, we're counting 1, 5, 10, 15, 20, right? And for the 300 rule, you're memorizing. The first one is 300, the second one is 150, third one is 75, right? And so then you have those numbers. And then, hold on, and then it would be once you, so let's say, so if you have 300 over 6, hold on, let me see. If you get over if you go over 2 boxes, it is 300 over 2, which equals 150. Okay, so you could do the 300 rule 2 different ways. You could either memorize that this is 300, this is 150, this is 75, this is 50, and then tell yourself, if I see this here, it's 300 beats per minute. If I see it here, it's 150 per minute. If I see, right, you can do it that way. Or you can say it's 300, and then however number of boxes, you just put 300 over that number, right? So if it was here, it would be 300 over 1. 300 divided by 1 is 300. If it's over here, you'll say it's 300 divided by 2. 300 divided by 2 is 150. If it's over here, you'll say 300 over 3. 300 divided by 3 is 75. So if you memorize 300, 150, 75, you don't have to, like, if you don't remember how to calculate 300 divided by 3, you know? But that's what that number is. Get it? Want to do it one more time? Okay.
I guess my question is, how do you can use either the 1500 or the 300?
Yeah, you could use either one.
Oh.
You could use either one.
Okay.
It's up to you what you feel comfortable and what you remember at the time, right? So they say that the 1500 rule is more accurate, more precise, right? Because we're doing like 21, right? 22, 24. We're eyeballing it a little more closely. Whereas the 300 rule is more like the average, the range, okay? So again, 1500, 5, 10, 15, 20 divided by, or 1500 divided by that number, right? 300 rule, either you memorize 300, 150, 75, 50, whatever. You memorize that, and then wherever the next one lands, you're like, oh, I remember that box means 150, so that's the rate, and you're done. Or if you don't remember, then you're like, okay, I know it's 300 over something. Okay, 300 over how many boxes is between the 2 peaks, right? So since if we were doing the 300 for this one, we would say, okay, I'm going to use the 300 rule. How many boxes are between the 2 peaks? 1, 2, 3, 4. Okay, so it's 300 divided by 4. And then that would be my answer.
It's like RPM.
All right, tell me.
Yeah.
Is 300 divided by 4 75?
So 300 divided by 4 is 75, yes.
So the 3 is 100.
Yes, I apologize. Yes, I apologize. I missed that one, yeah. So it's 300 divided by 1 is 300. 300 divided by 2 is, hold on, 150. 300 divided by 3 is 100. 300 divided by 4 is 75. Yes. Okay, we're cool? Okay. And so the irregular ones now, we use the 6-second rule, right? And the 6-second method can be used with an irregular rhythm to estimate the rate. Look at the R to R peaks intervals to see if they are the same or inconsistent. Count the number of R waves in a 6-second strip and then multiply by 10, right? So usually when you go to the, they calculate the 6-second strip, they rip it out, and all you have to do is just count how many peaks you see, right? So in this case, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, right? And so then it would be 10 times 10. 10 times 10. So however many you see, you just times it by 10. If you only saw 6, 6 times 10. If you only saw 4, 4 times 10. If you saw 20, 20 times 10.
I'm
Yes.
sorry, you said this was a 6-second strip?
This is 6-second strip,
Oh, okay.
and it's a 6-second rule, and it's for irregular. So anytime you measure it and you're like, oh, these are not equal distance apart. Even if it's 1, that's not 6, like regular, same distance, you use the 6 seconds rule because it's irregular. Questions? Good? Great. Yes? Is it not there?
You know, I'm still not there.
Okay, so I will, can someone send me an email so I can re-upload it for you? It's supposed to be. I apologize. I'll re-upload it. So again, determining the rate, we do 6-second method, rule of 300, or rule of 1500. But like I said, guys, you can do this, but you can also learn just to identify by looking. And you'll see how if you exercise your memory and practice it, and what I tell students to do is, since I will be only testing you on the strips that I have been teaching you, right? Oh, by the way, you guys have your books, right?
Yes.
Good. So you're going to be practicing, and so it is a quiz. It's going to have other things on there too, because if you're going to end up in HVU one day and you're going to have to read strips, if you're going to be a telling, you got to learn it, right? But I'm just letting you know the ones that I'm going to mostly be testing you on, okay? All right, so, but the ones in the books, they're a different ones. There's so many different kinds, all right? And I'm looking for ballparks. I'm not looking for specific, you know, like exact number. So ranges, I take ranges. I'm good with that, okay? So here's an example of regular, okay? Like we see, okay, and again, my pictures, I think I have like a few pictures here that shows you the actual strip. No strip looks like this really. This is so perfect, right? So this is a normal QRS T wave, right? Atrial. Here's the P's. See them? Here's a QRS. See them? And here's a P. Here's a T wave. Okay. So to calculate heart rate, we already mentioned what to do. We do the 1500, the 6 second, depending on if it's regular, irregular, or the 300 if it's regular. Okay. Now let's analyze some rhythms. So remember I mentioned that we're going to have some words to help us identify what the problem is, or we can have numbers, okay? So the calculation helps us with the numbers. If they say 0.20, right, or the words will tell us, okay, if it's wide and bizarre, right? 120, greater than 120 for QRST is the same thing as wide and bizarre, because greater than 120 is wider than it should be. That you see the point? So you got to learn both, okay, to be able to get your answers. Okay, so we have 5-step method. We already mentioned this, okay? Determine regularity, calculate the heart rate, identify, and examine P waves. So this is how, if you're looking at the picture, you can identify. So we said if the P waves are there, but they're wonky, weird looking, too many, or something's wrong with them, usually what's the problem? Where is the problem? The atrium. Okay, so we're going to look at the P wave. Then we're going to measure the PR interval. Okay, so that would tell us what's happening with the P to let us know if it's a P problem, atrium problem. Then we measure the QRS interval. And if that looks wonky or different or weird, then we know it's a ventricular problem. Okay? Okay. Normal sinus rhythm, we mentioned already. This is what a normal sinus rhythm is. It's regular, we see P, we see Q, R, S, T. Okay. But here are the numbers, okay? So it's regular, 60 to 100 rate. PR interval is 0.12 to 0.20. QRS is less than 0.12. And what do? Nothing. Because this is normal. If we did something, we were hurting them. You continue to monitor. Okay, so now sinus arrhythmias. We have sinus bradycardia. So bradycardia is fast or slow? Slow. So this is regular, right? So if it's regular, if we were to measure, right, so in 1, to here, we say, okay, I don't want to pick that one. I don't want to pick that one. I don't want to. Oh, I like this one. It's right on there, right? So we would pick it. If we couldn't tell, then we would do the 1500 or the 300 rule because it's regular, right? Okay. So we would say, okay, from here to, where did I say? Here to here, we would count 5, 10, 15, 20, 25, 30. Okay, 30, 1500 divided by 30. And then it's plus 1, right? 31. So 5, 10, 15, 20, 25, 30, 31, 1500 divided by 31. Or I could say 300 divided by 1, 2, 3, 4, 5, 6. That'll also give it to me. Got it?
Yes.
Because it's regular. Okay, so what do we do? So here's the numbers that go with it. The rate is 40 to 60. We can manage, right? What does this number remind us of? What part of the heart signals this rate? AV node. The SA node is 60 to 100. So the P wave sinus and upright, PR is 0.12 to 0.20, QRS less than 12. Now, the treatment, if someone is Brady, treat only if symptomatic. So you're gonna find that some people, if they're stable, most times you leave them be. So if a person is Brady and they're stable, there are no symptoms. Stables mean no symptoms. They're not feeling woozy with the dizziness, their blood pressure is not high or low, or nothing's happening, their just heart is slow, okay? So nothing. If symptomatic, we give IV atropine or a pacemaker, external or implanted. So that's our treatment, okay? So what might cause this to happen? Wait, let's go to the silent symptoms first. So we can have syncope, we can have altered level of consciousness, we can have hypotension, we can have decreased urinary output, or heart failure can develop if we have sinus bradycardia and it lasts. And we can have this because non-cardiac disorders such as hyperkalemia, intracranial pressure, hyperthyroidism, okay, vagal stimulation with deep sleep, Valsalva, vomiting. We can have a cardiac disease, SA node disease, so the SA node is not working, so the AV node has to work. Myocarditis, MIs, and it could be drug-induced like beta adrenergic blockers. Okay. Also take note of my highlights, okay? That's important. We have sinus tachycardia, okay? Again, we see regular. Okay, so we're gonna do the regular, 1500, 300, or we could just look at it and be like, they're all regular. I see PQ, RST, oh, it's sinus, so it's tachycardia, right? We could do that, but we could also measure it. We would find, oh, this one is right on there. So we have 1, 2, so if we wanna do 300 divided by 2, and then if we wanna do 1500 is 5, 10, we have 5, 10, 11, 12. 1500 divided by 12. We could do it that way. Okay? Or someone might mention the numbers to us. So it's 100 to 150 beats per minute. Our P waves may be superimposed because it's so fast that the P could enter into the T and you can hardly identify which is which. PR, 0.12 to 0.20 still. QRS, 0.12, less than 0.12. Treatment usually resolves on its own. Treat underlying cause. So what is causing the problem? So when I was in senior year of high school, I developed Wolff-Parkinson-White, which is a condition where you have an ectopic place in your heart that's sending extra signals. So my heart rate would go up to 220 beats per minute. And in the beginning, I didn't feel anything. I just knew my heart was going fast. So senior year, I didn't do anything about it. Went to college 4 years, I felt it. I would go to the hospital. I think I went to the hospital twice because I felt a little symptomatic. But then by the time I got there, it resolved and they were like, you're fine. And I'm like, oh, gosh, how embarrassing, right? Because they came and collected me. And I'm like, eh. When I was in nursing school, it would happen again. By the time that, though, I was placed on atenolol, which helps the heartbeats, right? And the contractions. Then by nursing school, the stress of nursing school and all the other issues, then I started feeling lightheaded and other problems. Then I got it obliterated or ablation. I got an ablation. So, but this sinus, again, resolve on its own or treat underlying cause. So the underlying cause was my ectopic signals, so they had to go and burn it. That's the treatment that I had. Or before they did the procedure, they gave me the Tylenol. Okay. The other thing too to note, the symptoms could be chest pain, palpitations. That's my thing was palpitations, and it could cause anxiety. I didn't have anxiety. I was stressed out though. I mean, I was worried. The one thing, like I could tell, the jugular vein, you could tell it was like, boom, boom, boom. I was like, what the heck is that? There's a creature inside of me. No. Okay, treating underlying cause, decreased heart rate with beta adrenergic blockers. That's what I did with a Tylenol. You could take a Tylenol, you could take metoprolol, and get medical history such as caffeine, drugs, cocaine, amphetamine. I wasn't in any of them, including the caffeine. I didn't take drugs, so yeah, mine happened. I think it was a stress. I had stepmom issues. She ruined my life. I'm kidding. No, she didn't. I'm teasing. Yeah, so that's sinus tachycardia. Then we have more on, now these are the atrial arrhythmias, right? So we have PAC, premature atrial contraction, which this is what I say about you can tell, right? So you could tell this is normal, they're equal distance to each other, and then this one came a little too soon. Then this one looks the same as this, so it came back to the same. This one it wants to be, but it came just a little bit, but it was trying to get better. And then this one definitely came too soon, right? So it makes sense. Premature atrial contractions. The P waves are contracting sooner than they should, right? Makes sense. So there's that, and there's that, okay? All the others, if you measure them, they're just about the same distance apart from each other. Those are our peaks. Okay, then we have the wording. So the rhythm, regular, except for premature beats. Rate, determined by underlying rhythm. P wave sinus, except for the PAC. PR interval is the regular length, but may be prolonged, not measurable if in T wave. QRS is normal. How do we treat it? If it's infrequent, not treated. If it's frequent, we treat underlying cause with beta blockers, calcium channel blockers, or anti-anxiety medications. And if it's a run, we give amiodarone. And what a run means, oh, wrong way. Like you see how this happened and then it went back to regular? This happened and then it went back to regular. A run would be, this happens and then right next to it will be another one. And then right next to it will be another one. So that's a run, okay? Then we have the SVTs, or proximal atrial tachycardia, supraventricular. So here, the problem is the P and the T, we don't know. They're not there. So we lose our P's, and these are actually the T's. So we lost our P because it's that fast. So what do we have? It's regular. The rate 160 to 250. P waves, not be identifiable, buried in the T waves. PR, not measurable, right? Because we don't have P's. QRS, 0.12 seconds. How do we treat it? Ventricular rate control, rhythm conversion. We have, if it's stable, we want to sedate them. Vagal maneuver. So the vagal maneuver is something that my doctor shared with me too before we started medication. So we know the vagus nerve is connected to our heart, right? And so what the vagus maneuver is, if I bear down as if I'm going to poop, I'm bearing pressure down, then it will stimulate my vagus nerve. And what it does is it actually stops the heart for a minute to reset it. And that can be very dangerous, right? If a healthy person does it, you don't feel it as much because your heart is healthy. But if a person who has heart conditions do it, then they're restarting the heart. The heart already has problems. That can be very detrimental. And a lot of people with heart condition, a lot of people, when they go to the bathroom, you'll find them on the floor. Last quarter, maybe 2 quarters ago, we had one of those. The guy was literally being discharged. His family was coming to get him. He said, let me go to the bathroom before I go. That was his last poop. Say it again? Right, like that was horrible, right? I felt like the feeling of I think his fiance had come to get, like, it was just, I was like, man, that was so harsh, boy. We all were crying. We were done that night. It's like, that's crazy. But yeah, it's super.
I can just hear that argument.
So what would they do, right? When they know a person has constipation, heart problems, what do? Laxative, stool softeners, right? Because so that you don't strain, or they'll tell you don't strain, right? Because it can hurt you. And so that whole vagus nerve too, when you get to OB, you'll hear about it again, because pregnant women, their bellies, they can't lie flat because the stomach can go onto the vagus nerve and cause them to pass out too, right? And so they have to lie on the left side to move the belly away from the vagus nerve. So that vagus nerve, it could kill you. Okay, so be aware of that. All right, so that vagal maneuver, that bearing down, helps to restabilize it. We have adenosine, beta blockers or calcium channel blockers. We have cardioversion if all else is ineffective. So there's a difference between cardioversion and defibrillation. So cardioversion is relatively elective. It's like, we know, we're watching you to see if we need to cardiovert you. Like, we know what we're doing, how we're doing it, when we're doing, like, it's not an emergency. It's calculated. That's cardioversion. Defibrillator is, get the AED, start CPR. Like, you're not waiting. Like, it's not elective. It's do or die, right? So that's the difference between a defibrillator and a cardioversion. Cardioversion is, you know it's happening and we're planning it. We're like, okay, we're gonna have to cardivert you now. You know, like, we've watched it and it's not really working out well. Let's do this. Whereas defibrillator, you're not asking. You're getting it done. Okay? All right, so here's an example of what I was saying, how it doesn't look cute. It's not very structured and clean, right? So this is a PAT with adenosine that they were given. Now we are into atrial flutter. So with atrial flutter, right, again, I'm going to give you something more or less like this, right? More or less. Most of the ones I give you are this. I might throw one that look like this in there, you know, because that's really what you're going to see, right? But even still, let's look at this. So atrial flutter. When you look at it, do you see how, like, rhythmic and, like, you know what the next place is going to be. Like, it's structured, right? So when I think of this, I think about a butterfly, right? They're rhythmic. Like, they beat the flutter. Their flutter is like calculative, rhythmic, same speed, same rate, like, you know? So that's what I think about. This is a flutter of a butterfly. So even though this doesn't look like this, but look how, and that's the other thing I say, if I draw a line, like, get your paper and put it across and draw a line, if you draw a line, the line can hit almost all of those humps. That means it's a flutter. Same thing here. If I draw a line across here, you see this is like they're right along the same line. Same thing here. This. It doesn't look like this, but it's so rhythmic, you can picture what the next one is gonna do. You see what I mean? So that's a flutter. Yeah.
So because it's atrial, those are all P waves?
Yes, these are all P waves.
And there's no T waves.
So
or is it one's hit, the last one's hidden, and then the other ones are the
it's
P waves?
exactly.
Okay.
It's hidden. It's hidden. So this can possibly be a P wave, the T wave, but it can also start the P wave,
Okay.
right? So like this T wave is up here, and then these are the P waves.
Okay.
So yeah.
I have a question.
Yeah.
So on the bottom picture, there's 2 lines. Am I, like, missing
Oh,
something?
so we know that the EKGs are 12 leads, right? And so they are measuring different places and seeing the electrical signal in different views. So this is, we would say, a 2-strip, right? Like, so this is one view, this is another view, right? And other ones will show different sides. Like,
So
they could select which view they want, which angle they're looking at the heart. Usually the cardiologist would ask you, like, give me this one, and that way.
Okay. So, like, the bottom, you can clearly see the atrial flutter.
Yes.
And, like, the top one is less obvious.
So here we can see, like, this is where you see how the dips are? This is where the QRST is. Because you see how it looks different from here? Yeah. But this one is more visible to me, and so this is the one I would look at. But they're saying the same thing, but at different angles, different viewpoints. So yes, so atrial flutter, we have regular or irregular. We have atrial 250 to 400. P wave, sawtooth, that's another way they'll mention it. A sawtooth, like the jagged edge of a saw. The PR not measurable because we can't really locate where the P starts, where the T starts, like Megan was saying, right? QRS, less than 12, nothing happened to the QRS, right? We still see it very clearly, okay? So how do we treat it? Focus, control ventricular rate, clotting formation. So that's our focus. We're trying to not let it get to the ventricles because the ventricles shouldn't feel it. Then we want to see, okay, so the problem is we say it's fluttering like this, right? So it's not exactly a quiver, but it's close to a quiver. It's not contracting the way it's supposed to, right? It's more like it's too fast. So that means the fluid that's in there, the blood, won't all come out because you need like the good contraction that brings it all out, right? So that means the blood is going to stay behind, and any blood that sits and doesn't move is able to clot. So that's why we have clotting formation, and we're watching out for that. So that they're going to be on aspirin, Plavix for the clotting, and the digoxin, beta blocker, channel blocker, at amiodarone for the contraction or the heartbeats. Okay, so if it's stable, we do anticoagulants because we don't want them to clot, and we do a cardiovert as we're watching. We're like, okay, they're stable, but we don't want them to stay there. If they're unstable, we definitely want to cardiovert, do a cardioversion. And recurrent flutter, radio frequency catheterization. So we're going to look in catheter ablation so that we can burn out that area that's causing the problem. So some of our nursing interventions, right? We're monitoring closely for decreased cardiac output. What tells us we have decreased cardiac output? How would you know we have decreased cardiac output? Not the weight, because it's not like it's not leave. Well, it could eventually, right? Because if it's not going to get to the kidneys, eventually it won't be peed out and you might accumulate it, right? Yes.
Capillary refill.
Capillary refill can tell us, yes. What else? Blood pressure can tell us. One more thing. Level of consciousness, right? If the oxygen carries oxygen and we're not getting enough out to the body being organs, and which includes the brain, so we might have level of consciousness issues, right? So we might eventually have urine output issues, but that's so much later that it's not as big of a deal in the beginning. So that fluid, we worry more about our brain. Are we going to get oxygenation? Are we going to get blood circulating through all the organs? Okay, so let's see. We said ablation. So the causes: mitral valve disease, hyperthyroidism, pericardial disease, primary myocardial disease. Okay, let's go to atrial fibrillation. So fibrillation is more of the quiver, right? Now, it's an atrial problem, so that's why we see the QRS, okay? But look at our P's. What I see is, I hardly see a P wave. I see little things that look like P, but do they look like the beautiful flutter? No. And you see how this one looks different from this one, looks different from this one? Like, you can't really mimic each one like the flutter did. So there's a problem with the P. We can tell that. There's no problem with the QRS. So we know it's an atrial thing. It's long. There's a lot going on in here. But how do we differentiate from the flutter and the fibrillation? The fibrillation is not calculated. It's just going up and down. It's doing it like this dancing motion. Like, I don't know. It's going crazy. But this is called atrial fibrillation. So atrial fibrillation, also known as AFib. Oh, by the way, and I know I'm going to have someone ask me. It's okay. It's okay. I'm going to tell you that now. It's okay. I don't care how you spell the words. I just care that it looks like something that I can recognize. So if you write atrial fibrillation and you spell fibrillation wrong, as long as I can identify that it says fibrillation and not flutter, I'm good. Okay? Please don't write AF. Say it again.
We do shorthand like AFib?
Yes, you could do AFib. You could do AFib, right? But don't put AF, because AF, right, could be atrial fibrillation or atrial flutter. And I've had people put both. This is not all that apply. You're going to get it wrong, okay? Because it's one or the other, all right? Because you know all that apply, you could get, if you get, like, you get one, and you get partial credit. You don't get partial credit. Give me the right thing. Okay, so, yeah, so we have grossly irregular, the rate 400. Look how fast that is. There's no way that we're getting good perfusion with this, right? So this is bad. Fibrillation waves, coarse and fine. So the difference between coarse and fine, coarse is when it first happened. We can relatively see the waves a little bit more. Fine is it's been a while, the heart is weak, and we can hardly see the wave, right? And we're going to see a little bit more when we get to VTAC, what that means. PR intervals, not measurable. We can't measure them. QRS, not affected. It's normal. How do we treat it? We focus on ventricular rate. We don't want it to affect the ventricles, okay? If it's stable, anticoagulant, again, because it's quivering, it's not contracting, we want to help with blood clots. Unstable, cardioversion. We got episodic AFib, radiofrequency catheter ablation. So if it keeps happening, they're going to just burn the space. That's what ablation means. They burn the area so that it doesn't cause problems again. Oh, do we have time for class activity? We do. Okay, we're actually going to do a different, because we did our rock, paper, scissors before. So I want you to get into your groups and put these in order. Sorry, one who's going to have a crumpled piece of paper?
Almost do it, man.
Okay, so don't touch it yet until I pass it out to everybody. Oh, let me stop this.